This episode of Simulation Nation is brought to you by Avkin, your one-stop shop for wearable simulators and everything standardized patient.
Welcome to Simulation Nation. Today we are talking all things birthing simulation. So we are going to do a deep dive into all of your different offerings that are out there on the market, talk about costs, talk about features, and kind of do a full analysis of what your options are inside of your simulation lab.
Yeah, and I want to make sure that we're very clear that this is not the period/contraction simulator that they put on men in a mall somewhere.
Like the TENS machines.
Yeah.
What malls are you going to? You've seen that at malls?
Yeah, well, not me. I don't go to malls, but I've seen it on Facebook on malls. So I spend a lot of time in Facebook Reels, whatever. But, I think the idea is that you for this, it is specifically for teaching of healthcare professionals in a simulated setting, right? And typically that is in the simulation center at a community college, university, hospital.
Not painful contractions.
Right. For men whose wives want them to experience something before they actually go into labor themselves.
Okay. Yeah. So I think in general, birthing is a challenge inside of simulation because I think that in sim, when it comes to med surg or it comes to site community, we have so many options in terms of what we can do for the scenario. The scenario is really kind of, the world is your oyster and
Sky's the limit.
You can pick really anything. You can go off of a lot of experience. I think in birthing, especially in an undergraduate nursing setting, you only have so far you can go, right? There's only so many different scenarios you can come up with. You have postpartum hemorrhage, you have shoulder dystocia, you have, your normal birth. You could potentially do a visit, a prenatal visit. That's not as common though. You can do a preeclampsia.
Well, but again, for normal or some of the ones that are, I don't want to say necessarily abnormal, but definitely emergency right?
situations.
You can add things in like drug addiction, lower socioeconomic status, or maybe English isn't their primary language. You can add some things in to, I don't want to say complicate, but make it more adaptable to the population of people that they're going to care for within their
But I also think that when you think of undergraduate nursing and the level that they're going to be at, to include a shoulder dystocia and a postpartum hemorrhage, you're not going to get into the nitty gritty of what their socioeconomic status is. There's going to be very little of that.
No, but if they're a low resource person that didn't get prenatal care, that's going to impact, it's not going to impact shoulder dystocia, but it might be impact preeclampsia or postpartum hemorrhage. All I'm saying is you can add some, again, like you said, there's only so many things that you're going to be able to include as far as objectives go. But the idea with having that human-to-human connection and having people understand that, I think it's super important, especially in today's day and age where there is we know what states are really struggling with infant mortality, and also women that laboring women. So I do think that there has to be some awareness. And I guess that's probably the SP educator in me that is there's so many things that we can bring into this that would be really, really cool. But I also agree with you as an ER nurse extraordinaire, that's where I spent all my time. There was so many different options from a med surg perspective as where you could go. There's so many different health systems, body systems, right?
I just think that as a SP who's been the one in the bed, it's when you do a med surg sim and there's different dynamics and undertones in it, you can go so far into it and you can get that richness out of it. Anytime I had it in birthing, you're so focused on delivering the baby, you're not talking about all of these other things. You're way more focused on the contractions.
Maybe it's just in the debriefing process. Maybe
I think that it's way more in a sense of okay, let's talk about, is it realistic that this mother is going to have, a car seat to go home and things along those lines. And if she doesn't, what are the resources? But when you're focused on these emergent situations like a postpartum hemorrhage, shoulder dystocia, and they are emergencies, there's very little that you get into the nuance of who that person is. And I also think that is a challenge in general for that simulation field, is that anytime there's birthing that happens, right, there's so much involved in it. You have loved ones. You have, all these things. And as a mother who has had children recently, it's like your biggest fear is anything that's going to happen with the baby. And that, I feel like, is a very universal experience, is that it's like when you're in an emergency situation, you just want to make sure that your baby's okay. And that's the only thing that you're going to be concerned about.
Right. And I mean, again, to be fair, I did not teach labor and delivery in simulation. That was not my area of specialty, nor did I dabble in it, because somebody else had that already in our area. So you know a lot more about it than I do, because you played from the SP role. And the other perspective is that when you're teaching within the curriculum, a lot of times women's health, or women and children, right, is one semester, but it's peds mixed with, the maternal fetal. So that is there's a limited even amount of time in the semester.
Surface,
yeah,
yes.
you really. Yeah. I mean, again, it's on NCLEX. It is something that needs to be addressed.
Yeah.
But we are training them to be generalists, so there's only so much that you can do. But it is one of those things that, from the SP educator in me, I think a lot about opportunities for communication and education.
I really liked one scenario that we did that was a visit where she was having symptoms of preeclampsia and concern about, swelling and things like that were going on. And there they really discussed her, socioeconomic status, things that she was having trouble with her partner, things like that. And you were able to go a lot deeper, right? Because you're not in the midst of delivery. I think that the challenge people find themselves in is that if they try to add in those pieces to the delivery sim, you just never get that far, because if you're in the midst of contractions, you're not going to be also discussing what's going on at home, right? You're like, get the baby out of me and give me an epidural, like that's
just
what the
like
focus is.
any woman would
Anyone in the hospital is talking about, right? So I think that also the landscape has really changed for birthing, because we started out and only had a very limited amount of birthing simulators that were on the market. And now there's really kind of 3 different facets in terms of what we're looking at for birthing simulators. So I've gone in and done a lot of different research when it comes to what the different options are, what the different features are, as well as discussing price point and things like that. So really the 3 main buckets that it falls into are, you have your traditional mannequins, which is going to be Laerdal, Elevate, and Gamard. And then you
Gamard was the first. Gamard was really, for a long, long time, the only birthing simulator.
With Noelle. Correct.
With Noelle, yes.
And then you have your lower cost wearable option, like a Mama Natalie or Mama Berthy. And then you also have the...
Or Pardo Pants as well.
Yeah, Pardo Pants I have left out of the discussion just because it is so basic that it really is very limited on what it can do. It's very limited, so I did not include them in the analysis. And then you have the higher tech wearable option with Avbirth. So those are kind of your 3 buckets that they fall in. And really the price point is significantly different kind of as you go through all of these different options. And inside of mannequins, that's really where they focused also in the medical realm and focusing in on what the medical needs are for birthing, as well as included in the nursing. So I want to talk a little bit more about the 3 different options that you have with the mannequins and what that looks like. So I'm going to start with Gamard, who has Victoria. And with Victoria now, you have a lot of different options in terms of add-ons, which I think that they have their base model, and that is more fitting for the undergraduate market in general of what the options are. And then you have the options for add-ons. So they have C-section options. They have the ability to add on, a postpartum hemorrhage at the end, but you have to swap out the bellies for each of them. So basically it's one base and then you swap out the bellies as you need. So the biggest thing that I've heard when it comes to Victoria is the challenges that a lot of people have is that there are a lot of add-ons with a lot of hidden costs. So a lot of times they are struggling in terms of figuring out what exactly they need when it comes to the different add-on options and then evaluating that from a price point. I think sometimes where simulationists are struggling with this is when you have kind of that Cheesecake Factory menu where it's like you have too many options in a way, and then they're trying to sort through what do they actually need, what can they afford based off of the grant or funding that they have, and then trying to make that all work. And I think that that's one of the consistent challenges that we're seeing.
Well, I think it's also really important because, again, we got, at the end of my time at the university, we got Gamard mannequins, and they had features that were not turned on. So the software, it was already programmed. All they had to do was turn on the feature if we were to pay for it. That was pretty frustrating to me, I have to say. Like from a person knowing like my mannequin could do these advanced features. Maybe I never needed it, but it was like it was there and they paid the money to put it in. Why would they, why would they just wait to have me say yes?
That's business, baby.
But well, I don't think Avkin will ever do that. Let me just say that.
But it's a business person making that decision.
I just didn't like it. I didn't like it as an educator.
It's a business person.
But the other thing is when you look through the different mannequins and they say they have these capabilities, okay, what is the price for all those capabilities versus what is the base model price and what is the base model things? And I think we, again, at Avkin, we get questions like that now, right? Whereas like, what's the cost for disposables? Do we have to repurchase the software for the products? That kind of thing, because it has happened over time. Again, businesses have to keep their lights on. They have to pay people. They have to sell things. But you want to make sure that you're not looking at that checklist of a million things and going, we can do all of this, but the base price is actually
That's where I've heard a lot of people struggle, is that they'll go to the conferences and they'll see the full capabilities and they'll get the marketing, list of all of the things that it can do. They go back and sell it to their dean for the low price of X. And then they find out, actually, if I want it to do all of those things, it's not going to be that price point. It's going to be significantly higher. So I just think that that's one area to consider.
Ask lots of questions.
Yeah, is to consider when it comes to all of the different capabilities and getting a better understanding of that, and also knowing that what is at the conferences is going to be the full thing. Yes. And that, again, you will probably have to pay additional than what the base model is. So be aware of that. But Victoria does fall as that mid-tier option when it comes to the mannequins. So when you look at Elevate, anything for Lucina is going to be higher in price point. It is more designed for the medical market, much less focused on the undergraduate nursing, much more focused on kind of those higher levels of being able to do different features with that. But it is a significantly higher price point. You would have to do a cost analysis to decide if the features of the Lucina are worth the price point based off of what you want Victoria to do. Because like we just discussed, it does depend on how many add-ons you're getting. So if you're doing all of the add-ons, the price point might add up to a Lucina, maybe more than a Lucina. So that you just have to consider in terms of what are the things that you need and where that add-on's going to get you.
So it's really interesting that you say this, and I'm just going to pause for a second because I want to explain to those that are fairly new to simulation and maybe not know the history. And this is not like, this is the anecdote according to Amy, but I think historically this has been, Gamard started as the lowest price option for simulators, regular simulators, right? And they were really targeted at EMS and more simulation programs that couldn't necessarily afford, a lot of mannequins, right? Yeah. So they were really kind of general, basic. And then Laerdal was really nursing focused and really focused a lot on the nursing market and what the nursing program needed. So they were kind of the middle level as far as cost went and also capability. And then the Elevate, which used to be CAE, which used to be Medi, were started by anesthesiologists, like the products that they created. So when they first came out, to increase the blood pressure of the mannequin, you had to increase the blood fluid volume in the mannequin. And you couldn't necessarily set a dial to say, I want it to be 140 over 90 or whatever it was. Yeah. So they really, again, it was really, they thought like anesthesiologists, they programmed it like an anesthesiologist, but it's really headed for the medical market. So just how you've described those two, it does seem to kind of line
up,
right?
The history of who they are. Yeah. And I think that that's the piece with, we've seen Victoria taking more stride in terms of market share when it comes to birthing simulators.
Yes, right.
And I also think that makes sense for the features and the capabilities of it, because it does seem like, again, they are more of the one-stop shop, and it does seem like the other two, with Lucina focused more on the medical market, and then Mama and being more focused on the nursing side. And really, Gamard is that middle spot.
Right, but the reason that the Victoria can be so advanced is because Gamard has had a birthing simulator for the longest amount of time. Yeah. For years, Laerdal sold Gamard birthing simulators, right? So just know that that's probably why they can even be as advanced as they are. If they all came out at the same time, I think it'd probably be a different story. But they probably are capable and able to serve a higher market because they've just put so much R&D into their birthing products.
Yeah. And so then with Mama Ann, they are on the lower price point side out of the 3 birthing mannequins, but they have much less capabilities. So they are more focused again on the nursing side of things. There really isn't going to be a lot of crossover when it comes to an IPE experience or an interprofessional experience because, again, you just don't have those same capabilities. So you can't perform a C-section. I believe that their blood reservoir is smaller than the other 2. You don't have as much options when it comes to kind of the little nuance, bells and whistles, things along those lines. You can still do basic functions. It still does have, dilation. It still does have the controls with the software and things along those lines. You have the option to do a patient monitor, things like that. But in terms of cross comparison, and almost if you had a chart between them, there is a significant reduction in terms of capabilities when it comes to the Laerdal birthing mannequin. And again, that reflects on price point. So it is all decision making, right? Of saying, sure, I'm good with what these features are. I don't need any more than that. I'd rather pay the lower price point, and being okay with that. Or asking yourself, like, yeah, no, I think that it would be better for us to invest in Victoria where we can get a little bit more, potentially do some add-ons in addition. But really, we all know that it's like to get funding for an add-on is going to be very challenging in terms of what that is. It's like, once. You get it or you don't get it. So to think like, I'm going to get it and then come back, that's harder. But again, undergraduate nursing programs at a community college don't need a C-section component of it. No. So it is just the questions in terms of what scenarios do you want to run? What do you have? I do think that it's a little funny that they do really emphasize birthing positions because I just think in general it's like,
a mannequin?
Yeah. It's like they're on their back or they're on their left-hand side. Like, you know what I mean? Like, it's like you're not getting them up out of the bed in any way. So I do think that that's comical. But they do advertise that.
And they have shown it a few times. It hasn't quite always worked out, but they do show it a few times.
It's not the best. But yes, they do have that. But I think that in general, people do not love the fact that with the mannequin, there is limitations in terms of birthing positions, again, being able to get them up and moving, and what they can do actually, in the birthing scenario.
Well, I'll also say that there's complications for specifically for the Victoria, I know. And again, I never did labor and delivery. It wasn't me. It was one of our customers that was talking about the challenges of doing postpartum hemorrhage because between each one, they basically would have to take the abdomen out and the genitalia off in order to get the blood reservoir refilled.
It's similar as well with cervixes in terms of being able to increase dilation is that you are changing things out and stuff as the simulation goes on. And again, swapping out bellies and things like that. I do think that in some ways it's like, it makes sense, right? Because postpartum hemorrhage, you can do that as kind of like take a break and then come back and do, like now mom's in distress and we have postpartum hemorrhage. It doesn't have to necessarily be in the same birthing option. But I do think that it's hard on the techs. That means that your ops person is basically sitting there waiting, going in, switching it out. I don't think that was considered, right, in terms of how hard that can be. And then the other thing to discuss that we haven't yet is the babies. Again, in terms of the baby options, I would say that
so Gamard, this is the baby that goes with the simulator.
Yes. Okay. Gamard has the better option in terms of what they can do with the baby, but they really advertise Super Tori as kind of the infant mannequin that you would purchase.
So after delivery.
Additional cost, right? So again, all of that's going to be additional cost. Again, similar in price point. Laerdal has the least amount of capabilities with the infant simulator, but it depends on how much you're emphasizing that in your scenario. If you're not doing a full infant head-to-toe assessment and you want them to see cyanosis and all these other things, the question is, do you need it? Do you need a more advanced baby? So I think that, again, it comes down to what simulations do you want to do? How many are you doing? Because again, if you're doing one birthing simulation a year, that also is going to make a big impact versus if you're doing 4 or 5. If you have a midwifery program, again, huge difference. But I think all of these different factors are just to consider that typically, like again, you're going to look at price point and then you're going to look at what the capabilities are of the product. And if a mannequin does fit the bill for that. I remember for us, what we did a lot in terms of the preeclampsia simulation was we had the mannequin, but we would be the voice as a standardized patient. But we had so many issues with the students not seeing that mom was actually, passing out and seizing and things like that, because it was not super obvious that that was happening.
Yeah.
And it would almost have to be that you were cueing the students to let them know mom's seizing, and then they'd have to, okay, and then get involved. And so you're always going to have these different issues in terms of having the students even being able to pick up on the things that are happening in the scenario to feel like it is real.
So rather than having, to me, what I hear you saying is rather than having the S be the voice of the mannequin, because historically, again, as even with the adult simulators, they don't, even if the patient's saying, I'm having chest pain, ouch, please help me, somebody, they don't even hear them because they're so focused on everything else, is going on,
doing
right?
A million different
is
things,
to have maybe the SPBF family member in the room to say, hey, do you see them? They're acting funny. They're not responding. What's going on? Something like that.
I think so. I will always say, because I have done family member for a mannequin, it is still so hard to make it anything realistic. Again, as someone who has been in the birthing room for, my sister-in-law, and then myself as the person who is out having the baby, it's just so, the things you say, the things you do, it's just not what would happen. And again, you're having to do so much prompting. And I think that that's a challenge. So that brings us to the next component with Mama Natalie and Mama Birthy. So Mama Natalie was the first product that came out from Laerdal as a wearable. And really it was designed for assisting third world countries with different emergency birthing scenarios. So Mama Natalie is only hemorrhage, or you can do, a non-complicated birth. But basically you have that option between those two. And then they came out with a second model, which was Mama Birthy, which you can do shoulder dystocia. Both of these products are not designed for a high fidelity, US market. They were designed to travel easy. They were designed to be donated. That was really kind of the heart behind the product. And being able to go over to, Africa and South America and things like that, and go into clinics and actually do kind of some emergency situations to help midwives and things along those lines in different areas.
So this is already practicing.
Mm-hmm. Oh, yes.
Mm-hmm. Midwives or folk medicine people, but giving them the abnormal. So they were used to birth. They had seen that, but now let's give them some abnormals or some things that some complication. Exactly. So to help them think through what they would do in these cases, because as they encounter them, they have low resources. Yeah. They're not going to, they're not necessarily going to have a hospital 20 minutes down the road. Yeah. What do they do? Yeah. Right.
And I think that with the thought process in terms of designing this product, we really see that there was such a need in the market that people were adopting this model into U.S. market. So again, I wore the Mama Natalie. I did it for a few years where I wore that product because I think that there was such a need for wanting to have a real person in the scenario, having the communication element, and being able to have it where they actually are able to position and walk around and do all of the different things that are needed for the birthing experience.
Right. That's think about birth. It's like that high stress, high tension.
And it's the energy in the room. I know that sounds so theater of me. It sounds so
but it's true.
But it is. It's just it's a whole different thing. Again, I've been in the room with someone who was a real person laboring, and I've been in the room with a mannequin laboring, and there's a different energy in the room. There just is. But I think that you can see that it was people were saying this is a need, and that's why they started adopting basically a product that was really never designed for the market, but they were able to say, I'm okay with the no technology. I should not say there's zero technology in it. So no technology inside of it. It is purple, like a purple cloth. So again, it's not something that you can, it's not silicone. It doesn't look like a belly. You can't feel anything inside of the belly. You can't position baby, anything like that. But basically, there is a hard board on the back, baby's inside, and then basically it is strap that goes around, and you unhook that and then loosen it, and that is cervix. So basically you can't feel cervic dilation. Really it is nothing. Baby's head's there, and that's really kind of the experience that you get with it.
Who
and
loosens the strap?
The person wearing the product.
Okay.
So basically your job is to loosen the strap once you get to the point where you're saying, okay, I'm ready to push, things like that. And then you are the one that holds the baby and kind of delivers the baby yourself with your hand. So basically you're pushing baby out, they're receiving baby, and that's kind of the experience. So there's no mechanics.
You put your hands inside, so they it looks, basically it's the color of blood. And the color of the Mama Natalie. It's like, so that if you get blood on it, right? No,
you can definitely see the blood if the blood gets on it.
Then,
it's easy to wash. You can wash
Clearly,
it.
I don't
teach you. Yeah, you can wash it because it's cloth, but it's a very dark purple. It doesn't really match the blood color. But basically, then you have baby come out, and you're pushing baby out, and then there's a lever on the back that you open to allow blood flow to happen.
You have put your hands inside the product, so it's like little, think about pockets on the side, just like it's on your jacket, right?
It's kind of like a cloth that's pulled taut, and then basically you are able to slip your hands inside of it.
And then you're pushing the baby out.
Yeah, you're really more like holding the baby to not come out is more or less than pushing it. You don't really feel a resistance when baby's going out. It's also that the baby was designed to be able to travel. So really, if you think of it, it's kind of like a Mylar balloon that has like edging around it, and then you fill it with water. So it's really, again, something that is easy in terms of like it'll just come right out. So you really almost have to be
because the water's
holding
heavy
on
and
to
pushes it out.
Yeah. And again, thinking back on it, I did a lot of Mama Natalie Sims before I had a baby. I pushed that baby out way too fast. Way too fast. Way too fast.
Yeah.
That baby was falling out. So again, thinking about that too in terms of like really practicing how you're doing contractions and the pushing and all of those different pieces to it. You know, again, it needs to take some time. So that's a whole nother piece that does make it a little more challenging, is trying to make it authentic with them catching baby, but not necessarily pulling baby out. And again, the same resistance that they'd feel is they're feeling it as me holding baby versus it being a natural flow. I have not worked with Mama Birthy because that did come out after. But from my understanding, Mama Birthy is smaller because it doesn't have the blood reservoir, but it does have the hips to basically do, or the pelvis to basically do that, the baby getting stuck and then being able to do shoulder stocia. With that product, you are more limited in terms of what they can do to resolve it. Because again, if you think about it being on the person, you cannot really put them into like full legs behind their head and things along those lines. So there is only so much that you can necessarily do in terms of recovery. But I think it's a lot more in terms of them being able to see, oh, these are signs of a shoulder dystocia, we need to intervene at this point. And then it's kind of, again, makeshifting to go along with that.
Is the baby the same?
I'm not sure because I do think that it has to have a little more structure, but I know that it's still transportable. So if I'm remembering correctly, certain parts are not necessarily the water, but then other pieces are, just so that it doesn't weigh the same amount. But really anything for Mama Birthy or Mama Natalie, you're looking at about $1,000. So everything is going to be significantly cheaper. Like I said earlier, these products were meant to be donated. They were meant to travel. They were really used for, again, if you think of like nonprofits going over and doing education, like that's really more of the heart and messaging behind it. It has just so happened that a lot of people have adopted it into the U.S. markets to, again, make up for the fact that they wanted to be able to have that live person. But you are going to face some drawbacks. But the benefit really is price point. Like that's the biggest benefit that you're going to have, and that you can do some of these very basic things like postpartum hemorrhage, shoulder dystocia. Again, not necessarily the best at doing them, but cell blood come out and all of those different components to it. So I think that also depends on how much you want your, let's just say like for an undergraduate situation, your midwife, that's really kind of more of your embedded participant coming in and delivering the baby, and is not necessarily there for the learning experience, but more there to move the simulation along. And it's more about the nurses administering medicine, talking to the patient, things like that, positioning,
helping with the legs,
positioning, things along those lines, like
coaching them through the contractions.
I would say it's a good first introduction, but it is going to be basic. And I think that that's something that, again, I'd encourage you to play with it before purchasing. Like see it, wear it, use it, go somewhere that maybe they have it. But I think the
other thing that we get feedback on when the people ask about our birthing simulator is the fact that does the SP have to do anything?
Yeah.
And I think that you being in labor, having a contraction, holding the baby, knowing when the baby, there's so many things that the SP is controlling in that. And I think, as you have pointed out, very like from a SP perspective, it's a lot to ask in a short period of time.
It's really hard to maintain all of the different pieces at the same time and make things feel natural and understood. Again, think about the fact that it's like you're wearing a hospital gown. If you end up sitting on your hospital gown, weird. Well, now I don't have access to the belly anymore. So now I have to awkwardly figure out how to be able to get my hospital gown out from underneath of me to be able to then get my hands inside. And then from that point, I have to find the lever without being able to see anything while I'm still answering questions, while I'm still trying to remember feedback, while I'm still communicating and trying to make things look natural and act. You're doing all of these things. So it's in terms of a standardized patient, you would need someone who's more advanced. Putting someone in as their first sim, it's challenging. And I will say that the only sim that's harder than birthing is being a pediatric mom. That's the only one that's harder. So it is the second hardest sim to do as a standardized patient because you have to think of breath control. You're trying to maintain all of these different things. And it's also really hard when you do not necessarily know when the contractions are happening, because then you're also trying to watch a clock to figure out when do I need to have my next contraction. So that's a whole nother component where you're trying to keep all of these pieces together. There are different tips and tricks. Like, again, we used to have sometimes where it would be the loved one would like squeeze your hand when it was time for you to start the contraction, but then they're also getting distracted and ask questions and things. So it's not necessarily the foolproof plan, but it is something that, again, you can make it work depending on the objectives, depending on the scenario, and depending on budget. I mean, honestly, if you can afford $1,000 and that's all you're going to get, it's better than nothing, So I think that that's kind of the options. You do have to buy them separately. Mama Natalie and Mama Berthy do not work together. It's either one or the other. So you have to choose between those two. And then the last option that is newest out on the market is the Avbirth, which was designed by Avkin. So basically that is your higher tech wearable option. It was designed for undergraduate nursing. So in terms of the different medical offerings, there is a limitation when it comes to C-section, when it comes to, urinary catheterization, different features along those lines. But you are able to do postpartum hemorrhage. You can do shoulder dystocia. You can do breech. You can do non-complicated birth, but you do have a lot of options. And the part that I think is the best is that the product was designed for standardized patients to be able to wear with ease. Again, this was something that I really took a lot of the things that I didn't necessarily love from my experiences and say, these are the things that I would want to know. So with the Avband, which is basically something that looks like a Apple Watch, it vibrates when the contractions are starting, and then it increases, and then it comes back down again. So it's that same feeling of kind of that wave of the contraction. So you know when it's happening, and again, you can react and respond. I also think that the part that's really important is that there is also a orange button that can alert the control room. And in the birthing simulations, out of any of the ones I've done, birthing is the most that it's very easy to miss things for physical safety for the standardized patients. So an injection that needs to happen. Well, if there's 5 people doing 5 different things and that injection needs to go in the leg, it's very easy for that to get missed by the person who's facilitating and watching, because they're watching 4 other people doing 4 different things. They might miss that needle that's going in. So that's something that as the SP, you can see these things happening and you can react and respond based off of where the injection pad is or something like that to bring note to what needs to happen.
Yeah, but I will say this. The other thing is, because it did happen, again, full disclosure, Megan did get, in one of the med-surg sims, they were supposed to be checking your blood sugar and using the controls for actually checking the blood pressure, but because it was so realistic, they actually went through and did the...
Yeah, I knew I was going to get stuck, though, so that's my own stupid fault. I knew it was going to happen,
but what I'm saying is, like,
stop them.
With that, it is... The students get so bought into these simulations because they are live people wearing wearable simulators that they believe that they're supposed to be acting as if they were in a clinical environment.
Yeah.
And they're not necessarily looking for the injection pad. So it is really important to be thinking about that physical safety of your SPs, removing anything out that is not supposed to be used, making sure you're revealing in pre-brief where they're supposed to be giving the injection to remind them.
I just think that in terms of physical safety, it's the easiest one for things to get missed. And so being able to have something like that.
Well, even hyperventilating, getting carpal tunnel syndrome from the SP, like them being able to communicate like, hey, I need a quick second for a break or something.
Well, again, just something's wrong. Something's wrong, and that there's needed attention for that. So I do think that that's an important part anytime you are going to have a standardized patient in the birthing scenario, which I do think is important. And then the other thing that I think is the biggest benefit is being able to do the different positioning and really being able to actually simulate how it would work with having that loved one there, that live person there, and being able to position them in different ways around
ambulating
the room and
them
like
at the start of the simulation, which is what most laboring women that don't have epidurals do.
Yeah, and you have the option as well to, again, have midwifery being able to come in, being able to do different movements with that. You can, again, simulate having doulas and things like that, which, again, are becoming much more common inside of the birthing centers and things along those lines. But there is the opportunity to really have that person at the center of it. The biggest concern that I have is that women of color are still facing increased mortality rates in the U.S., and it has only gotten worse. It's not getting better.
Nope.
And I feel like a very important part is that we need to start looking at the way that we are training healthcare professionals when it comes to this. And I think that, again, seeing that it is not improving is a sign that what we're doing in sim is not necessarily translating to the bedside. And I think that this is a concern that we need to start bringing these conversations into sim. I don't think anyone can necessarily pinpoint why, but it's a conversation that needs to be had. And I do think that starting to have simulations around this can start addressing the disparity that's happening.
Because women of color can actually represent themselves in the simulation setting.
Well, and I think that it can bring out different scenarios in terms of them being able to offer feedback, them being able to talk about their experiences.
They have a seat at the table.
Yeah, and I think that that's the part that, again, this is coming down to needing there to be more representation. And honestly, I would urge anyone who is doing maternal simulations to really look at the statistics. Look at your state. You can go on marchofdimes.com and look at the full analysis of the state. And I think it's just something that people aren't aware of. Even until recently, I was not aware that Delaware, which is where we're from, was on the top 10 list for infant mortality rates. Didn't know that. Just had 2 children. Didn't know that. And it's these kinds of things that I feel like we only know about the extreme cases or if we're involved in that world. But I think that this is an important conversation to have to discuss how we can improve maternal health at large, and looking at our piece inside of simulation and saying, okay, what can we do to start to make impact? And what I really like with the Avbirth as well is that you do have the 3 different skin tones that you can buy with the product. So you can buy one base and then have the 3 different skin tones so that it matches
3
your
different babies
patient
too.
pool, and have the babies that match the skin tone. And I think that, again, that is the important piece here, where it's like, if we're only focused in one area and we're not looking at the bigger picture and we're just going in it to check a box, I don't think that we're going to see what we want to be seeing. And I think that right now it feels like it's everybody else's problem but our problem, the mortality rates. And I think that this is an area that it's like, sure, we can't fix everything, but we can fix where we are. And I think that if we did really start to emphasize this in the education that we're providing, we'll see better outcomes. And I think that we need to take a hard look at how we're educating nurses and doctors going into this field for women's health.
And I think, again, I just got back from a weekend with a bunch of other sim leaders that I've been very, very well connected to for the last 10 years. And, several of them have our birthing simulator, but one of them is actually using them for family practice residents who cannot get clinical locations. So they're not OB residents, but they're family practice residents that need so many births and to be exposed to it. And so it's going well even in that environment. But the idea of having that diverse population of people, having them have a seat at the table, and that's kind of what I was going back to in the beginning of this, of giving that. I'll never forget the time that you told me, and it's just such a small sample, but you were talking about, and I don't know if it was on social media or something, but a woman of color said that she went in after birth or after some type of surgery, and she told the surgeon that, or showed the surgeon the scar, and the surgeon was very surprised and said, normally you get a really big scar. And the way that she interpreted that was that maybe they didn't have the best care. And so they were being given their incision wasn't being cared for the most. But in actuality, from the nursing perspective, I know that people of color are much more likely to get keloid scars, which is much more significant scars. But that surgeon would not have known that was the impression from that actual patient, unless they were talking about that in a debrief during simulation, to know that he or she needed to explain that further of what would commonly happen. So there can be those simple communication barriers or misunderstandings that if we just understood each other a little bit more and we had honest conversations in that debriefing, I think it could make all the difference in the world.
I think it's also the power dynamic, though, is that, again, she didn't feel the ability to say that when it happened. Why did she not feel comfortable being able to address that right then and there as it's happening? And that in itself speaks as the power dynamic. But I think that in terms of women's health, it is that when you start to have that in terms of simulation, where they are there to provide feedback and they are there to have the open conversation, and that is the intent, right? I think that that's also the difference. It's like, we're bringing you in because we want to hear your feedback.
Absolutely.
And we want you to have that experience. It does remove some of the, national power dynamic that is a struggle in terms of women of color and being able to share their experiences and have their voice in that. And I think that, again, it's the larger conversation that, of course, there needs to be more research. Of course, there's a million things, right? But I think that in terms of us looking, especially May being Women's Health Month, looking at this and saying, let's really look at what we're doing inside of our birthing simulations and decide, do we think that this is the best representation to teach our learners to be able to go out and care for patients? And I think that that's where we have to look at all of our different options in terms of equipment. But again, I would really encourage everyone to think about kind of throwing the baby out with the bathwater. Don't look at what you've been doing in the past. Don't just do it because that's what you've always been doing it, but really analyze and see what would be the best way for my students to learn, and approaching it from that way. And if you aren't aware of March of Dimes and looking at kind of your score for your state, I really encourage you to look into it. It's fascinating. And honestly, I think that a lot of this also just comes from being aware that this is out there and that we need to know what's happening in our communities and our areas. And those of us who are educating healthcare providers, we need to be aware of that and be able to take hard looks at what we're doing and own our piece of it and own what we can control, which is, our area and what we're doing.
And again, it's the voice, right? It's like, it's giving people voice. It's also acknowledging what it is, right? Yeah. I think I always go back to one of my colleagues at the university, and she was talking about the impact, when you're a bedside nurse, you have you're impacting one patient at a time, but when you have students, you're impacting cohorts at a time, right? And so you can have such a larger influence in the simulation center because you are educating the next generation of providers.
Yeah. And I think that, again, it just, oftentimes it feels like, well, what can I do, right? I can't do much. There's not much I can change. And I think that it's just being able to look at the parts that you can impact and being aware of that and then making those necessary changes. And I think that as a woman who receives healthcare, again, as a white woman who receives healthcare, it's very different. But I do think that in general, there just needs to be more of a focus and more of a conversation. And I think that a lot of times we get a shrug of it, just like, this is how it is, right? And I just think that that's not acceptable. And we need to start looking, if everyone started looking at the areas that they could control and that they could make a difference in, I think we'd live in a very different world. And I think that that's important.
Yep. Well, it goes back to the bigger conversation about patient-centered care.
Exactly. Yeah.
Right?
And so again, if we're focused on patient-centered care for the bedside, let's have patient-centered simulations so
Absolutely.
that then we can start implementing that in the education piece of it. So I think that that's all great. All right. Well, thank you for joining us. Again, this is going to be coming out the last week of May for the last week of Women's Health Month. If you guys are interested, please look at March of Dimes and learn about your state's information. And we are also be including a blog post to share more about the differences and comparison of the different birthing simulators simulator options. Thanks, guys.